Hi, and welcome to this episode of Weight Loss Information. And we're going to continue with our GLP-1 series because it's important that you have accurate information and get a full range of information from different professionals and from people who have been on the GLP-1s today. And our guest today is Michelle Ledford, who is a nurse practitioner at Beltline Bariatrics here in Atlanta. And I've had the pleasure of knowing Michelle, oh my gosh, for 5 or 6 years now. But her life has changed so much in these years. She's had babies and she's working from home. And oh my goodness. Welcome, Michelle. It's good to have you here.
Thank you so much. It's great to be here.
And when you and I started, we were doing support groups together for the post-op patients.
Yes, we were.
Yeah.
Really
And
fun times.
yeah, those were fun times, and support groups are so important. So,
Sure.
you have gone from working mostly with the bariatric patients to the people using GLP-1s and medications, correct?
Yes, yes,
Yeah.
I have.
Okay.
Mhm.
Go ahead.
Well, I'll kind of give you a little background on that. So, kind of, when I started with the practice in 2018, I did a lot of bariatric surgery post-op care, and then kind of, with the rise of the GLP-1s, I'll say kind of around the launch of Wegovy 2020, 2021, got my obesity medicine certification. Really just found a love and passion for obesity medicine, and I've been really honed in on it the past 4 years. So yeah, it's been so great.
I love that, and you
Yeah.
really have done so much work. You were brand new in this field when we had met,
Yes.
and you just caught on so quickly, and then you went and got that certification. So you're a great person to help our listeners understand when GLP-1s are the right option and what, all that information. So we're just gonna talk about the increase and when did GLP-1s, I know that they've been around forever in the capacity of like with diabetes and et
Mhm.
cetera, right? But in the
Mhm.
weight loss world, tell us when they came on into the scene, how did that happen? And what did you see in your practice in terms of increased use of GLP-1s?
Yeah, so I feel like Ozempic was kind of the medication, although it's for diabetes, was the one that showed so much promise in weight loss. And so with that medication, they launched Wegovy shortly after. And that was really, we had Saxenda, which was prior to that, which is the same drug as Victoza for diabetes. But it wasn't showing the amount of weight loss that Wegovy was showing. So really, I feel like everything kind of took off with Wegovy after it launched. And it is a great medication. It really helps patients with appetite control, portion control. It helps with cravings. So it's really been a great tool. And with that has come Zepbound. So I feel like the more these medications have kind of gotten out in the media, the more people are aware. And I think it's really great because we're recognizing that obesity is a chronic disease, and we have more choices now, more options for patients. They don't have to feel like they have to jump straight to bariatric surgery or, some of the other medications that were previously on the market. We have a little bit more efficacious medications now. So it really is, an exciting time to be able to provide all these options for our patients for obesity medicine.
Was it kind of a happy accident with Ozempic that they found the weight loss?
I'm not really 100% sure. I think that they were noting it in their clinical trials, and I think they kind of ran with that, and kind of, then came Wegovy, and that just kind of launched everything off.
So when Wegovy came on the scene, it's an injectable, and I
Mhm.
think, you know, even myself, knowing that it's an injectable
Uh-huh.
medication, I don't fully understand this injectable thing. Is it like a shot like you would give penicillin or
Yeah. So I hear this question a lot, and it's a great question because I come across a lot of people, and naturally, who likes needles? But what's really great about the pen injectors is you actually don't have to deal with the needle at all. And I'm talking on Wegovy and Zepbound. Ozempic, you do have to place the needle on it. But just in terms of obesity, we'll talk about Wegovy and Zepbound. So those are pen injectors. So very easy to use. You just take the cap off, unlock, and you inject yourself. So you don't have to handle the needle. It's painless. I've heard nothing but good things about it, in terms of ease of use, and again, no pain. And I think this is a big deal for patients who maybe are a little fearful of needles, that that's a little bit more
Mhm.
reassuring to them, that they don't have to physically do anything with the needle or even look at it. So
So
that's been great.
it's not like insulin where you measure out your own dose.
No, it's no. So I will say, Lilly did come out with the Zepbound vials, and you do use an insulin syringe to draw those up. But the benefit of that program, is it's a little bit less expensive, and it also Medicare, Medicaid, and uninsured patients get, a discounted price if they don't have coverage through insurance. So unless it's the
Oh,
Zepbound vial, you do the pen injector with Wegovy, and Zepbound, which is again no needle handling.
okay. So, and it's injected into the abdomen, correct?
Yes, and it can be in the thigh or the arm, but preferably in the abdomen.
All right. So when you, oh gosh, I'm jumping ahead of myself here, but when you prescribe one of those, there's no, I have to teach you how to use this sort of thing.
Well, we have demo pens in the office, so
Okay.
certainly we could have you see the device, practice with it. We can even, inject your first dose in office if you're uncomfortable with it. I've done that multiple times as well. So, but it comes with a really good instruction guide. There's good YouTube videos out there.
I'm
So I would
sure.
say that yeah, I would say there's a lot of ways to learn how to use it, but your provider can definitely assist you with that.
I'm chuckling because my
Mhm.
all my grandkids are at the age where they're getting these um, pre braces things in their
Uh-huh.
mouth or the roof of their mouth, and you got to take this little hook and you got to twist the thing. And I'm like, I probably watched 25 of those YouTube videos. And I'm like, I still can't get this dang thing to.
Yeah, I know. You can find anything on YouTube,
I know, I know. So
good or
the
bad.
medications that people were using prior
Yeah.
to these newer
Mhm.
GLP-1s like
Mhm.
phentermine and are those
Yes.
like are we no longer using those or are those still an option for certain people and how do you decide?
Yeah, so great question. I think it kind of varies from provider to provider. I'm very comfortable utilizing some of the generic medications, Qsymia, Contrave, alongside the GLP-1s. And it certainly does depend on the person because, again, not everyone feels the same about even with the injector pen, not seeing or feeling the needle. They don't want to try an injector pen first. They don't want to jump straight to Wegovy or Zepbound. So then we can talk about the some of the other oral medications. And some people don't have the insurance coverage. I mean, again, because we're doing better with pricing, but we're not exactly where we need to be yet. I think things are going to get better as time goes on. Kind of the trends that have kind of been going on with the prices of the medications going down. I utilize all medications, and the percentage of weight loss is different, but it can still be helpful. Even if it isn't, to the scale of a, GLP-1 medication, they can still get good weight loss and get started. I think the important thing is to just have the conversation with a provider that can kind of give you all of those options because they're still good options.
Good. And oh my gosh, my head is just racing because I
Uh-huh.
was talking with a patient
Mhm.
last week in the last episode and she had had bariatric surgery and was following up with the GLP-1. And the place where she was getting it, there was no provider per
Mhm.
se. So there
Mhm.
was no conversation between doses, incremental, as she titrated up on the medication. And she was dosing herself according to how little she wanted to eat.
Yeah. So, and was this a place that was doing something compounded, or was it Wegovy or Zepbound?
Um, I gosh, I believe it was one of the brand names.
It was.
I
Okay.
think, but I could be wrong. So I know that the compounding ones people were being able to get at like,
Mhm.
diet centers
Mhm.
in the strip mall, right?
Yeah. So I don't do anything compounded personally. I know that out there are some, decent places in terms of, pharmacies that are slightly regulated by the FDA, but they don't have the clinical trials. So that's for me. I just, like the comfort of the Wegovy and the Zepbound for the clinical trial purposes and the other medications for clinical trial purposes. But what I would say is the most important thing about the GLP-1 medications is education. You have to understand how the medication works. because therefore understanding the medication helps you to kind of mitigate some side effects that could potentially happen. And, I think one of the most important things that I like to impress upon my patients is that because society has taught us in the past, don't eat and you'll lose weight, right? So, with that mindset, if you have that mindset and you're going into getting a medication that's going to completely suppress your appetite, you're thinking, okay, good, I'm not hungry, so I'm not going to eat. But you can't do that because that will get you in a lot of trouble, especially in
Absolutely.
terms of muscle mass. You can definitely lose muscle. So it's important to understand that even if you're not hungry, you do have to eat, smaller, frequent protein based meals. Because the medicine, takes away your hunger. You get full very quickly. So you really have to listen to your full signals. This is a little bit easier for a patient that's had bariatric surgery because they understand how it feels. But somebody who's coming onto a medication has never felt like this before. I think that it's so important to mitigate side effects and also to be as successful as possible is to do the education. That is the most important
Oh
piece.
my gosh, I it just terrifies me. It
Mhm.
terrified me to hear what she was saying because it's like people have got to have the education. There's a lifestyle that goes along with the medications, just like there's a lifestyle that goes along with any kind of weight loss. It's not just the weight loss. And I know that when people have struggled with obesity for so long, they just want that weight loss, but that education is so critical. So let's pretend that I'm coming in to see you and it's our first meeting. How would you go about and I come in and I say, I don't want to have surgery yet.
Okay.
I just want to try medication first, but I there's so much information out there and I don't know where to start, Michelle. What do I do?
Okay, yes. So I would say, first of all, tell me a little bit more about your weight loss journey thus far. So I want to get a good background. I want to get a good understanding whether you're struggling with increased appetite, large portions, what kind of, I'm looking at your history to see if you have any kind of metabolic disorders, fatty liver, pre-diabetes, kind of just gathering my head all this information to kind of formulate the best medication regimen. So I think a really good background and just letting you talk and tell me kind of what you're feeling, what you're going through, what's bothering you the most. I come across a lot of patients who struggle with food noise,
Yeah.
which is just the constant thought of food, and it's very, it's very distracting and it's overwhelming, and it's something that really impacts patients day to day. So what I can say is these medications, what I've noticed is it really, really takes away that food noise, and just that freedom alone is just so monumental for patients that sometimes they even tell me just the elimination of the food noise, despite, even weight loss, even if it's not as fast as they thought it was going to be, they're okay with that because they're
Yes.
able to get through their day. So, I just really try to listen to patients and meet them where they're at. So I would just kind of I do look at BMI. I think it is good to kind of talk about weight loss goals. We don't have to focus on that number 100%, but it is something to get a gauge how much weight you want to
Sure.
lose, because then I could think about the percentage of weight loss with some of the medications and kind of further tailor the treatment plan towards that as well.
So if a person has, I know you look at the complete medical history, which again,
Mhm.
I want listeners to understand. Please talk to a practitioner who
Yes.
is well versed, like Michelle, in these medications. Because if you have other comorbid issues, you want that practitioner to know so that you are put on a medication that will work with whatever's going on with your body. So if somebody comes in and they've got something like fatty liver disease, um, which of these classes of medication would you stay away from? Are there reasons that some things are contraindicated for certain patients?
Yes. So, fatty liver is definitely indicative of metabolic disease in the body. So, that
And can you
visceral fat.
explain that? Can you explain metabolic disease?
Yes. So when we're talking about fatty liver, we're kind of talking about that fat mass burden. So the fat is being stored around the liver. Usually, with that, we have some kind of insulin dysregulation in the body, and so some of these medications, specifically the GLP-1s, can help to target that insulin resistance, help the pancreas secrete insulin better to help it, move that fat storage away from the liver, helping with weight loss and also targeting targeting that visceral, that deep fat, which is around the liver. So, if someone's coming in with fatty liver disease, I would probably turn to a medication that I know is going to target insulin resistance, because it might be alongside the fatty liver, and really just targeting that fat around the liver, which again, the GLP-1s, that's a good thing that they're for.
So, what about fat distribution in the body? So, if somebody carries their weight around their belly versus kind of evenly distributed throughout their body, or maybe they've got the pear shape and they've got the bigger thighs, is
Mhm.
there a difference in medications, or are they all just targeted to help that fat dissolve or whatever it does? What does it do?
Yeah. So, obviously, burning fat is a goal with any medication regimen we do. Now, I will say again, the GLP-1s, they do target, kind of that abdominal adiposity a little bit better. And also helps with kind of the sick fat and the fat mass burden around the liver and the abdominal organs. So I would say someone coming in with abdominal fat, I would test them for insulin resistance if they haven't been tested for that specifically. And I probably would gravitate toward a medication that would target that.
Who would you not recommend a GLP-1 for, and what medication would you recommend instead?
So I think there's a lot that goes into that question. Absolute contraindication would be medullary thyroid cancer, personal or family history, or medullary or multiple endocrine neoplasia syndrome type 2. So
What
I
is
would
that?
Okay, yes, a very rare type of thyroid cancer.
Okay.
And yes, multiple endocrine neoplasia syndrome type 2 is usually a condition that can precede it. So it's not common. It's in 1 to 2% of thyroid cancers. So that would be an absolute contraindication. But if someone was on, the lower end for BMI without any kind of comorbid conditions, wanted to lose a little bit less weight, maybe 10 to 20 pounds, something a little more conservative, if they were the appropriate patient. I do utilize phentermine and topiramate quite a bit to help with appetite. To give you a little, the topiramate gives you a little bit of satiety, so fullness can help with night eating as well.
Yeah,
The brand name is Qsimia. Sometimes I tend to break it up into the generics if we don't see good insurance coverage, just because it makes it a little cheaper.
right.
But it really kind of depends on the patient and again, the comorbidities. And again, I think it is really important to make sure that you're getting the full story and you're really just kind of doing the best you can in terms of targeting goals for the patient and what their comfort level is.
Okay. All right. So what about the pancreas? Are there any specific contraindications? Because I know that I've heard about pancreatic cancer and GLP-1s. Is that a thing?
Not in any of the clinical studies. There is a warning for pancreatitis. This is
Okay.
usually related to gallstone pancreatitis. So, if they've already had gallstones in place, and then weight loss, especially fast weight loss, unfortunately can cause gallstones to develop, and then therefore, can cause cholecystitis. So I would say just, discussing with the patient symptoms for gallstones. If you had a high, if you felt like they did have gallstones, you could do a right upper quadrant ultrasound to make sure, because it carries a little bit of risk if you already do have gallstones of developing pancreatitis. But usually continuing the medication after a diagnosis of pancreatitis is typically up to the discretion of the healthcare provider. Now, I will say this: if someone has a pancreatitis in the past of unknown origin, we don't know why they got pancreatitis, I'm a little more nervous to prescribe. But if it was something like a gallstone pancreatitis, gallbladders removed, then I feel more comfortable. But you do want to watch. There is a pancreatitis warning. And then, of course, just the development of potential pancreatitis. So going over signs and symptoms of that.
So would that be true with like weight loss surgery, increased possibility of gallstones, any quick weight loss? So
Mhm.
it's not because of the GLP-1 necessarily. It's a
Mhm.
result of the quick weight loss.
Correct. And then weight gain can also cause it too. So they could already have gallstones that they didn't know about.
Oh, really? Very
Mhm.
interesting. Okay. All right. Very good. So when you've seen a lot more people, I'm sure, seeking GLP-1s, and to me, it started around the time of the pandemic. Is that
Mhm.
accurate?
Yes. Yes, and that's kind of when Wegovy was just kind of coming to market. But I mean, again, I think these medications are so wonderful. They're coming out with indications for different things. You know, Wegovy has a cardiac indication, Zepbound has a sleep apnea indication. So again, you know, all these different disorders and metabolic diseases, we're seeing treatment with these medications. So I think as we move forward and get even more, it's going to be, you know, even more prevalent that people, you know, seek them out. But I think it's important to know that you know, patients not to get discouraged if you know, because everyone knows about GLP-1s and, you know, if you find out your insurance doesn't cover and you get discouraged about the price, I would say it's still important to seek out help for treatment of obesity and that to have the conversation with your provider that, you know, there are other medications that are out there that can provide you some weight loss as well. And of course, just general education on lifestyle interventions also. So I like to also kind of
Absolutely.
say with the GLP-1s, it's important, even if you find out you don't have coverage, to not get discouraged. That it is a great option for medications, but you know, cost wise, it's not for everybody. So
Right. Are insurance companies becoming more accessible in terms of paying for these medications?
yes, I definitely think I'm seeing a positive trend with that. Now, you know, things change. I feel like even,
Right.
you know, the tide can turn. Um,
Sure.
but, you know, I think specifically in Georgia with coverage of the state health benefit plan. So, you know, teachers, bus drivers, postal workers, I think that was huge
Yes.
to get coverage for those patients. That was a large patient population. So I think, you know, that plan going into effect for coverage of obesity drugs was huge. And I feel like it just kind of is dependent on the company. But I think we're moving in the right direction. And I think the more medications that come to market kind of drives down cost. I like to use Wegovy as an example because Wegovy self-pay price was at $800. And then Zepbound came to market at 650. And so Wegovy dropped their self-pay price to 650.
Ah,
And then Zepbound came out with their vials to 499. So now Wegovy self-pay injectors are 499. So as you can see, competition does drive down price. And I
for
feel like, again,
sure.
yeah, and I've been seeing a lot of approvals too for Zepbound with Medicare for the sleep apnea diagnosis, which is huge.
That
So,
is great. Oh my gosh, I did not know that, and I'm glad to hear that. It's good for people to know.
mhm.
So, certain patients, in my experience, because I do the pre-surgical evaluations primarily, and at this point in time, I would say 90% of the people who are coming in to see me for a pre-surgical evaluation have tried GLPs and either they couldn't afford them, the insurance quit covering them, or they had side effects. How many people do you see that have side effects that prevent them from continuing those medications? And what are the side effects?
Okay, great question. So it really kind of the side effect profile with Wegovy and Zepbound is the same. And it really relates to kind of the slowed gastric emptying. So, you know, overeating, eating poorly. I usually tell my patients to avoid fried foods because that can make you sick. But the nausea, vomiting, diarrhea, and constipation are, you know, the highest reported side effects. So again, the education piece. So I'm telling them about all these things that could potentially happen before they get on the medication so that they can, you know, put things into place to mitigate it. So if someone comes in and has severe constipation, has a background of that, let's go ahead and get started on benefiber, Colace, Miralax, whatever it is. Start that before we start the medication to stay ahead of it. We're being aware that we have constipation. If we need to prescribe a medication for constipation, we can do that. So I think, you know, again, the education piece for, you know, some of the side effects really helps. I really do see quite a few patients who are tolerant of the medication because they listen to what I say.
Mhm.
So they're paying attention. And, you know, if people do start having side effects, that's when I kind of dive deep into kind of, okay, what are we eating? How much are we eating? How quickly are we eating? And kind of, you know, trying to reverse it that way. And then if it's just an absolute intolerance, just nausea all the time, no matter what, can't get over it, you know, especially, you know, if we've tried both Wegovy and Zepbound, because sometimes the symptom profile can be a little different in terms of doing better on one or the other. Then, and if they're, you know, qualify for bariatric surgery, I certainly refer them. But I would say when I do my initial consult with patients, if a patient does qualify for bariatric surgery, and we're talking about percentage of weight loss, I do discuss bariatric surgery quite a bit because it's completely transformative. I've been working with bariatric surgery patients for 7 years. I'm a huge supporter of bariatric surgery. It's the strongest tool in the toolkit that we have. I think that the medications are great, and I think that they are, great pre and post surgery. I
Mhm,
think they have their place.
mhm.
But also for patients to really understand, we're talking about percentage of weight loss and getting you down to the healthiest BMI that you can possibly be at, because we want to mitigate those secondary health consequences that can come on later down the road. So the hypertension, high cholesterol, diabetes, stroke, heart attack. We're trying to make people, be as healthy as they possibly can and live their best life.
And again, that's another great reason to talk with a trained provider
Mhm.
because you may say, well, I want to have this surgery, I want to have that surgery, or I want to just use this medication.
Yes.
And it may not be the most appropriate thing or medication for you. So, getting all of that information is really, really critical. And I'm glad that you mentioned it's another, there are different tools in the toolkit. And when we have a chronic disease,
Mhm.
we have to figure out which tools we have that are going to work best for each individual patient and
Exactly.
find out what's going to. So, when you talk about Wegovy and Zepbound, same medication,
Mhm.
different companies?
So, Wegovy is a GLP-1 receptor agonist, and Zepbound hooks onto the GLP-1 and GIP receptor, so it does make it stronger and does attribute to more weight loss than Wegovy. So it's kind of like an aggregative effect, the GIP on the GLP-1. Really helps again with that insulin working better in the body, helps a little bit better with cravings, food noise, appetite control, and has higher weight loss. So the weight loss on Wegovy is around 13.7%, and on Zepbound is about 20.2%. So that's, there is a little bit of a difference. And because Zepbound hooks onto two receptors in the body and not just one.
So, when you talk about 13 and 20%, are you talking about total body weight or excess body weight?
I'm glad you said that, because in terms of surgery and medicine, we kind of have different lingos. So, bariatric surgeon for weight loss, you're going to talk about excess body weight, and for medications, you talk about total body weight loss. So, I'm talking about total body weight loss. That's how it's studied in the clinical studies.
Mhm.
But that's a very good point, because that can get very confusing.
It
Um,
does. It
so, and
does.
it can be, a lot of things can be put out there, and it's a lot of misinformation, because
Yes.
we're not talking in the same language.
Mhm.
So it's important to, kind of clarify those things when you're talking to a provider.
Right. So I want to reiterate that to the listeners that if you talk to a practitioner about a medication, Wegovy or the Zepbound, you're talking about a percentage weight loss of your current body weight. If you're talking about bariatric surgery, the different surgeries will get a different percentage of your excess body weight off. And it's a very different conversation. So make sure, and that's confusing. So make sure you talk to your provider about that. So if people know that one of those meds, which one did you say is the 20%?
So, Zepbound. So, and with their high responders, it can be 25% or more. And when we're talking about total body weight loss and total body weight loss of gastric sleeve, that's about total body weight loss losing with the sleeve is 25 to 30%. So it's pretty much, it can be equivalent to gastric sleeve in terms of total body weight loss.
Okay, that's good to know as well.
Mhm.
Here's something that frustrates me a little
Mhm.
bit, not a
Yes.
little bit, a lot.
Okay.
When a patient comes in and tells the doctor, I want this surgery, I want the sleeve, I want the bypass, and everybody wants the sleeve because they hear it's the least invasive.
Mhm.
And they don't always get accurate information. And so when I do an evaluation, I make sure I go over the numbers with them. It's like, because there's science that says with the sleeve, you're going to lose probably 65 to 70% of your excess weight loss, or 60 to 65 with the
Mhm.
sleeve, right?
Yes.
70 to 75 with the bypass, and so
Yeah.
on and so on. And they're shocked. They're absolutely shocked by that information. So
Yeah.
make sure that you have this conversation with your provider, whether it's with the medication or with the surgery. And it's not that you're going to get to this specific number, but they've done enough surgeries, they've done enough clinical trials with the medication that they can give you a ballpark. And so that your expectations aren't so far off that you have the sleeve and you go, well, this surgery didn't work for me. I didn't lose as much weight as I wanted to. When you've lost exactly as much weight as that surgery is supposed to get off of you. Same with the medication. So make sure that you're talking. So does everybody come in going, I want the Zepbound because I'll lose the most weight, even though that may not be the most appropriate medication for them?
I mean, it kind of depends. Again, I think the GLP-1s are the most requested medications because I feel like they're out on social media a lot. I have patients coming in from TikTok. I know TikTok's a place where, the medications are widely talked about. And I love that, this is bringing a lot of awareness again to the chronic disease state of obesity and this great tools we have in our toolkit. But again, sometimes I do have to have that conversation, that real conversation, because I'm very upfront and honest. And I can kind of give a gauge in terms of because I've been prescribing for long enough, like insurance coverage and kind of the process you go through. And, I would say some people are kind of shocked to find out that their insurance maybe doesn't cover. They just assumed it would cover. And so having that conversation when they're kind of set on a medication can be a little difficult.
Mhm.
So what I would say to patients is keep an open mind. The GLP-1s are great medications. And I know I've said this multiple times, but you talk with your provider and you can also have another medication that's, effective as well. But I
Absolutely.
would say those are the most requested medications. And it is true based on clinical data that we know that Zepbound, is the strongest medication on the market for obesity right now. So we can say that because we have the clinical trials.
So how do you determine when a person is at a high enough dose? Because they may, like this woman that I was speaking about,
Mhm.
she kicked her. I said, well, you went into a medically induced eating disorder because she just didn't want to eat. She wanted to starve herself.
Right.
And so it was like a medically induced
Hmm.
anorexia.
Yeah.
So how do you tell a patient, listen, you're at a good enough dose? The dose is high enough for you. And how do you start them? How do you know when to increase them? And how do you know when enough is enough?
Right. So, kind of going on, the guidelines, they're on a dose for 4 weeks and then they're escalated to the next dose. The higher in dosage you get, the more weight loss you get. Now, you consider treatment response and tolerability with both medications going up. So, say I have a patient on 0.25 of Wegovy, they're doing great. They've lost 10 pounds. They've had no side effects. They really just feel more comfortable staying at that dosage. I say, okay, well, we can do another month. You can just let me know if you feel like the medication is not as effective as it was. Your weight loss kind of slows down. Your body's kind of telling you you're kind of ready for that next step. Now, I do have some people who do want to get all the way up to those higher tiers because they know the weight loss, and I discuss this with them, that the higher tiers do yield the most weight loss. So it really kind of depends on how much weight the patient's going to want to lose. It's very different than someone. So say someone comes in with a BMI of 30, has a little bit less to lose. Maybe they get to, the 1 milligram of Wegovy or the 10 milligram of Zepbound, and they're at their goal weight and they feel good. And we're deciding on a maintenance dose. We don't have to go up to the highest dose. It's again about communication and follow up. And I think that the biggest predictor of success is how well you follow up with your provider and you're having open, honest conversations.
Mhm.
And that's why I try to, portray that trust and, being a non-judgmental attitude when I'm talking with my patients so they can, kind of tell me what's going on and we can make the best decision for them. But you can move up every 4 weeks. That being said, that's not every patient is cookie cutter. So not every patient has to go up every 4 weeks. Certainly if a patient's experiencing a little nausea or doesn't feel great on a dose, maybe they get to, Wegovy 1 or Zepbound 10, they're like, I think I want to stay here. I'm losing. I don't feel great on it. Let's stay here. Or if they start having side effects and they want to say, well, I want to go back down. And I'm like, okay, that's
Mhm.
perfectly fine. We can do that. So,
Right.
certainly it really just kind of depends on the patient and how they're doing. But no two patients are the same. So it
Sure.
really does vary.
For sure. Do you experience very often people who, because sometimes the patient, can't allow them to drive the bus, right?
Mhm.
So they're on a dose and they've lost, they have no medical comorbidities. They're at a really healthy BMI, but they're like, but I want to lose more weight. But I want to
Yes.
lose more weight. And the provider's like, wait a minute, you're at a perfectly healthy weight. Do you experience that very often, or is that kind of a it doesn't happen very frequently.
Yeah, so I do experience that sometimes. And I do have to have kind of the real conversation. Now, I mean, I wouldn't say that I'm particularly strict about BMI unless we're getting kind of really low into like the 21 and less range, like
Mhm.
where it's like, and if I feel like the patient is nutritionally not doing what they're supposed to be doing, if you're just eating a couple bites of food all day long and your BMI is going down, 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 I'm not going to put you on that higher dose. I'm going to
Right.
take your dose down because, you know, there is a really fine balance between being healthy and
Yeah,
getting in the nutrients you need and trying to achieve a very, very, small weight,
right.
a low weight. So again, I am flexible if the patient is doing everything they were supposed to be doing. But quite frequently, more so what I see is they get to a high tier of Wegovy or Zepbound, and then they've had their goal weight and it's healthy and they're good, and maybe their comorbidities have resolved. Sometimes they want to go down in dose. They say, hey, I could eat a little bit more in this lower dose and I
Sure,
want to build muscle.
sure.
So because that's a huge, huge thing is muscle preservation,
Yeah.
especially with any kind of weight loss, right? So,
Mhm.
I see more often than that, but sometimes I do have to have a real conversation, and kind of say, hey, I understand your goals, but maybe you're only eating a couple bites of food. You're not hungry at all. Maybe we try to work on getting more protein in and increasing the muscle mass. And I try to shift their focus away from the number on the scale because
Good, good, good.
fortunately, that can be, the kiss of death sometimes. I think it is good to go by the number on the scale loosely, but I think non-scale victories, which Connie, you know about non-scale victories, they're
For sure.
extremely important and motivating. So, lab work, losing inches, not having to wear an extender in an airplane, riding a roller coaster, all these, hiking a mountain. I had a patient the other day who went to Alaska and she did not think she was going to be able to hike in Alaska and she was dreading the trip, and she did amazing and she did it.
Oh,
And
how fun.
that to me was so, amazing. Like,
Exactly.
it's so important.
And that's what I believe, getting to a healthy weight is about, being able to live your life fully
Yep.
and not be literally weighed down and unable to do the things that you want to do and have those comorbid health issues. Let's talk a little bit about that the muscle mass loss.
Mhm.
What is the comparison, would you say, between persons who have bariatric surgery and just take the medications without surgery? Do you lose more muscle mass with one than the other, or is it kind of equivalent?
I think there's a lot of factors that go into that too. How quickly a patient loses, if a patient's eating enough protein and doing strength training, because I really do impress upon them the importance of that. And at our office, we have a body composition scale, and I think it's
Right.
very, very, very important to look at that breakdown of the fat mass percentage, that visceral fat, and the muscle mass to really kind of get a good idea of where you're at. So, and a lot of gyms, what I'll say to patients out there, there are a lot of gyms that have like the InBody scale and composition scales. I think it's very important to look at your breakdown, because you can lose muscle mass in a decent amount. I think I see a little bit more with bariatric surgery, and it's typically the higher level procedures where a patient could lose 100 pounds in 3 months. It's kind of hard not to
Right.
lose muscle when you're losing that much weight that quickly.
Sure.
So I would say that kind of with the higher malabsorptive procedures with bariatric surgery, you can lose a little bit more muscle. But then again, on the same length, I have patients who have had, the malabsorptive procedures and they don't lose muscle because from the start they've, taken in the protein and they are doing
Mhm.
what they're supposed to be doing. And then some people generally are just blessed with excellent muscle mass. I've also discovered that.
Yeah, yeah, that's a good point, right? Genetics are not the same for all of us. I
No.
was talking to a woman today, and she had one of the higher end bariatric surgeries and has lost a tremendous amount of weight, and she's been kayaking, which she is loving. But she said her muscles are so deteriorated, or she's lost so much muscle mass that when she gets out of the kayak, it's hard for her to make her way up the little hill to get
Yeah.
out. So I think that it's really important, those body composition
Mhm.
numbers are probably just as important, if not more important than the weight itself, because your weight's going to fluctuate, but you want to make sure you're maintaining your muscle tone and even building that. And we'll talk about lifestyle in just a minute. But if so, if so, the International Federation for the Surgical Treatment of Obesity, the big medical body, of course, their stance is And you said it in a way too that bariatric surgery is the strongest tool that we have in terms of you're going to lose the most weight in the quickest amount of time. Maybe not that that may not be completely accurate, but it is. Can you explain that? Why is bariatric surgery um, the strongest tool in the toolbox?
Well, we know, you're physically changing the anatomy of the body. So you're physically making the stomach smaller. You're physically putting patients into a malabsorptive state. And so the weight loss yield is much higher. And again, from those clinical studies. But I don't think, in my opinion, like how I kind of practice and despite kind of what you just said, I would say that, utilizing a medication in certain situations, especially if the patient's more comfortable with it, I would say, again, kind of just being open and honest and having that real conversation with patients. Because I think it's important to listen. And I think sometimes as healthcare providers, we get very caught up in the data and everything we need to tell our patients. And while I
Right.
think that's really important, I think it's good for us to listen and understand where the patient's coming from and,
Most
and really
definitely.
kind of meet them where they're at. So,
Mhm.
I would say that again, bariatric surgery because of the weight loss yield, because the malabsorptive procedures, you're physically not able to absorb the fat, the calories, the sugar. You're going to have the higher weight loss. But some of these medications are kind of mimicking. I have patients tell me who have had bariatric surgery that maybe they're not at their goal weight at the year mark, or they've regained a little bit, and I put them on a GLP-1, and they tell me, I feel like I have my restriction back. I feel like I did when I first had bariatric surgery. So,
Mhm.
I think that, and so many times I feel like surgery and medicine are adversarial. And I don't like that because we work
Yeah.
together and we work
Yes.
together better. I think they both have their places. But most importantly, the patient is the main focus and it's all about them.
I
So,
love that.
I think that's more so what I would gear kind of that question towards is really, yes, this is the research and what it says, but you also have to listen because,
Yeah.
you just have to give the most information you can and really listen to your patients and kind of meet them where they are.
Most definitely, because there are risks with surgery that don't apply to the medications as well, and so I think that's a really beautifully stated, how you put that. I do wanna talk about the lifestyle thing because, as you and I both know, and it's understandable, I just wanna be very compassionate about that. When somebody has struggled with a disease that is so frustrating, like the disease of obesity, for so many years, there is this, "Please just find me something to get this weight off of me." And I get that, but it's important for listeners to understand that there is no quick fix without a lifestyle accompaniment. You gotta have that lifestyle change to maintain what the surgery and or the medications can do for you. So let's talk about
Yes.
that from your perspective and how you point that out and make that really a critical element with your patients.
Yeah. So when we look at the pillars of obesity treatment, lifestyle is that first thing. And the verbiage is across all the different professional societies is it is the basis for obesity treatment. That means this is your foundation, right? And, it can be very frustrating because patients come to you after they've tried every diet in the book. They're just over it. They're blaming themselves. So I think it is, an important thing to talk about. And I think sometimes talking about it first it just depends on the patient. So, the second pillar of treatment is medication, then we have bariatric surgery. But it is so important to understand that the lifestyle is what matters. It is what holds true. You will metabolically adjust to surgery and also medicine, but your lifestyle interventions are key to helping you maintain that weight loss and continue with your success. So, and we tell our patients this too, even after bariatric surgery, after 12 to 18 months, your body adjusts, you're kind of at your new set point. And so at that point, you have to keep those lifestyle habits in place, or you could potentially start going the other direction. But we know it is the basis for obesity treatment.
Without a
Super
doubt.
important.
And, in the media, you hear, "You get off these GLP-1s and you immediately gain your weight back." Not necessarily, and not necessarily all of the weight. A lot of that does depend on lifestyle, correct?
Mhm, mhm. Yes, yes. I will say there have been some studies done to show that you will regain some amount of weight coming off of a GLP-1 if you have to, but that's not to say you'll regain all of it, and not every single patient does. I would say that's another situation where I tell patients don't panic. If you lose your job, you lose coverage, you talk to your healthcare provider, you come up with plan B. I always have a plan B for my patients. I don't just have one plan. And nothing's perfect, right? So say we put a plan into place and, even a GLP-1, if they're not responding appropriately, then we pivot.
Right.
We pick out another plan. Same thing with eating habits. Patients come to me, and when I talk about the diet and lifestyle piece, I listen to, what their daily life is like. Because if
Right.
somebody is, a single parent, they're working 3 jobs, I'm not going to tell them to track their food because that doesn't sound like
Right.
something they're going to have time for.
Exactly.
So there are plenty of diets out there, ways of eating that have good research backed evidence. I listen to what they've done that worked in the past, and it has to work with their lifestyle. They have to do it.
That's right. You have to make it so that it does
Mhm.
work with their lifestyle. And
Right.
that can be done. And that's important for people to understand. It's like we understand situations like that, or people who work in the medical field a lot of times.
Mhm.
They can't just stop and eat a full whatever every 4 hours. But learning about the lifestyle and implementing the lifestyle is really, really critical. And talking with your provider about how do I make that work with my lifestyle, and understanding the importance of protein, and understanding and the lifestyle between bariatric surgery patients is
Mhm.
pretty well mapped out. Is it that different for people on GLP-1s?
No, and to be honest with you, when I talk to patients about getting on Wegovy or Zepbound, I like to talk to them about protein shakes, just like we do with bariatric surgery patients, because sometimes as their appetite becomes more and more suppressed, and they kind of have maybe a little bit of an aversion to more solid foods, but we still need to hit those protein marks. Have them get acquainted with a protein shake over the counter.
Right,
Talk about certain brands. Maybe it's easy for them. I have a lot of teachers who they don't get breaks. They don't get the luxury of always sitting down or being able to
correct,
have a meal. So maybe it's that they do a protein shake on the way to work, and they do a protein shake for lunch. They have a real dinner, and maybe they can fit a protein based snack in there. Uh,
right,
but we're having these conversations and constantly changing things up as their schedule is changing. We're
right.
talking about have this with you, pack your food, kind of have these snacks in the
Yes.
car, prepare. So it does take, preparation to an extent, but it can be
Right.
as easy as harder as it needs to be. If you have a full
I
Sunday to
agree.
meal prep, great. We
Right,
can talk about meal prepping. If you're
right.
somebody that, I really love the Publix meals. They're already made, but they're by the
Yes.
section, and there's a meat and you can get a vegetable. You throw it in the oven, easy peasy,
Right.
done. There's
There,
your meal. You
yes,
don't have to think
so
about it.
many great options out there that can make it doable.
Yes.
People are like, "It takes so much effort to." I'm like, "How hard is it to open a Greek yogurt packet?"
Yeah.
Not very hard. How hard is it to open a cheese stick? It's like, let's make it easy and fit your lifestyle. Um, my son-in-law works for a racetrack, which
Okay.
is, in our area, we know what racetrack is, but racetrack is like a Quick Trip or a Casey's, or it's a
Yeah.
convenience
Yeah.
store with gas. And he was telling me that they're providing a lot of like protein drinks, or not protein drinks, but protein water, and these energy drinks that now have protein in them. And, everybody's trying to get in the protein market. There's
Yes.
protein popcorn, there's
Yes.
protein everything. And he was saying that if people are opting for like protein water over protein food, and in a case like a teacher, when you can have a protein drink here and there, it's a good thing, but not in lieu of food all the time.
No, that is a great point. Of course, I want you to eat real food when you can. It's just the times when it's not going to happen, and it's either you drink
Exactly.
that protein shake or you skip a whole meal. And I don't want my patients missing any opportunities for protein, because with this medicine, you can't sit down to a large meal at the end of the day. That's what causes the nausea and vomiting. So,
Ah,
and same with bariatric surgery. So, I want them to have something during the day. But yes, real whole food, minimally processed food is the best. We know that. But, there are other options to talk about with your
for
provider
sure.
for those times of like, oh no, what do I do? I don't have
Yeah,
time to get something.
absolutely. I don't take a lunch break. I drink a protein drink every day for sure. And it increases the amount of protein that I intake.
Yep.
The other thing that he said that, and this is a tough thing. He said studies are saying now that people are opting to not pay a gym membership so that they can afford the medications. And so the muscle mass thing is becoming more and more of a problem because people aren't exercising as much because they're taking the medication, and some people have to be like, well, I can pay for one and not the other. But there are all kinds of ways to exercise that don't require a gym membership.
100%. And I would encourage patients to go on Pinterest, to go on YouTube. Trainers are constantly putting content out there for free. You can get
Yes.
yourself an arm day, you can get yourself a leg day, an ab day. There's an app called Sweat that I really like.
Yeah.
It's a couple trainers on there, but the main trainer, Kayla Itzny's out of Australia. She does a 28-minute workout, body weight, demos the video for you. You can choose beginner, intermediate, hard. 28 minutes, you're done. Body weight, so you're getting the resistance
Love it.
training. There are different ways to exercise. It does not have to be you have to go to a gym. And I like to
Right.
tell my patients that too, because your daily movement matters. Getting your steps in matters. Choosing the stairs versus the elevator matters.
It
So those
does.
little movements that you're getting in every day, you're really helping yourself. So even if you have to split it into 3 10-minute walks to get out to get activity in, don't put pressure on yourself to have to meet some kind of standard that, oh, I have to go to the gym 5 days a week. And if I don't, it's not going to be worth it. So I'm not going to
Yeah,
exercise. So
no.
I like to tell patients to not, we want to set realistic goals again that work for them. And not everybody's starting out the same level of physical activity, but just want
Right.
patients to know that there are other options out there. You do not have to go to a gym.
That's right. I'll tell you what, YouTube is my best friend as far as
Yeah,
exercise. I'm like, I can do an hour yoga class for free. I don't
it's
have to
free.
drive half an hour to the yoga class, do an hour class, pay $30 for it, and then drive an hour home.
Yeah,
I can just go in the other room and do it.
yeah,
And young moms like
right.
yourself, man, when my kids were little, we didn't have YouTube, but we had Jane Fonda.
Yeah. I mean,
you
which
know,
is just as good.
yeah, and they would do it with us.
Yeah.
So make sure that you're exercising and
Yes,
not
absolutely.
not foregoing exercise because you can't afford a gym. Yeah,
Yeah.
I love that.
Yeah.
Okay, so I love this. This is great information people need to know. Talk to your practitioners, get the real information, get information on all of your options, but understand. And I love that lifestyle is the ground level for any kind of weight loss. It really boils down to you've got to have the lifestyle along with whatever tools best fit your circumstance.
100%.
Now, future of GLP-1s and medications, where do you see this going?
Well, I feel like we've kind of unleashed the floodgates. I feel like there's going to be a lot of medications coming up. I know specifically there's some oral medications that are coming up in the next year or so. Other companies are going to have their version of kind of the GLP-1 GIP. I think we're going to utilize other receptors in the body for even stronger molecules. I think the meds are going to continue to get better. We're going to continue to get more clinical studies, more indications for meds. Again, targeting things like fatty liver, these metabolic diseases that can lead to more serious health problems that we want to avoid. So I think we are on the precipice of seeing great things, but to remember that it is such a great time to reach out and talk to your provider if you feel like you've been struggling with your weight, because there's so many great options out there right now, and just getting in and having the conversation.
Hmm. Two last questions. What do you say when people say, well, I have to be on this medication for the rest of my life?
Mm. That's a great question because people do ask. That's very realistic. So what I say is obesity is a chronic disease and we do not stop treating. Maybe your treatment plan looks a little bit different. So in terms of Wegovy or Zepbound, maybe you're not at the highest tier. Like I said earlier, you go down to a lower dose because you feel like you want to do a little more muscle building. You want to get in a little bit more protein, whatever the treatment plan might be. But we have to remember obesity is a chronic disease, right? So we continue treating.
That's right. And that's what my response to that is, well, I take blood pressure medicine and chances are I'll be on that for the rest of my life
Yes.
because, I do all of the lifestyle things that say I shouldn't have high blood pressure. Genetically, I am a sitting duck for that. And so I'm going to take those medications. It's a chronic disease. So we treat it like we treat chronic ongoing issues. And what is the thing you say to people? Well, we don't know all of the long term side effects of this medication if I have to take it forever.
Yes. And so I think that's a fair statement. We don't have really long-term studies, but everything we are studying and what we are coming out with seems to be positive. So
Mhm.
again, as we get more indications, as we see these medications being studied even closer, I think we'll continue to get more information. And that's what we can go off of is, the clinical studies and what they're being indicated for.
That's right, and that's why we practice medicine. We don't have all the answers. We
Yeah.
work toward, we just continue to do research and get the data and go from there. So, again, the medications, nor the surgery, nor any other thing, no diet, no anything is the be all and end all. You are dealing with a chronic disease that you will have for the rest of your life. So again, like you said, the treatment plan may change over time, but
Mhm.
remember that this is a chronic disease and you are going to be dealing with this. So get as many tools that you can gather and use the ones that work with your lifestyle and what's going on with your health and your physiology.
Exactly.
Thank you, Michelle, for this amazing information because I think it's so important to have credible sources like yourself who have a certification and work in this field day in and day out. I can say, listen, I can give you this much information, but I this is not my area of expertise.
Mhm.
So thank you for sharing this and hopefully people will share this episode and get this great information out.
Yes,
And you're at Beltline,
I
which
am.
I love Beltline, one of the greatest practices I've had the pleasure to work with. You've got great surgeons, you've got great medical weight loss. It's just a great comprehensive program, great practitioners and education, the whole gamut. So they're lucky to have you and I'm grateful
Yeah. Thank
to
you.
get to work with you at times. And
Yes,
thank you so much for being on the podcast.
of course. Thanks for having me.
All right. Take care.
See ya.
Bye bye.
Bye.